Okay, I'm just going to do a very brief review of a very small PowerPoint here just to get us introduced to traction. We're going to talk more about traction next semester too, but just to get you the bare minimum, face value for studying for your quiz. All right, so these are the key points we need just for any components of traction you might see on your quiz, and then a couple of weeks later on your finals. So here's traction. Please know that traction is defined as the process of drawing apart, again, providing a force to draw apart body segments, usually with the goal of distraction. Distraction is the key, which is just the separation of bones, typically spinal segments, and that there is some controversy surrounding traction. So this is why we're just, not that we gloss over, but we want just some key information about traction. So know that there are mechanisms that can be applied to create the traction force, either manually with the therapist, mechanically with the device, or gravitationally body weight oriented traction. Right? This is how traction works. It's by creating friction in one direction while you create motion in the other. That's your standard traction table, using a split table for lumbar traction as well as cervical traction. So those are two mechanisms. That's basically how it works. We provide a distraction force. That's what we want. With spinal segments, typically it's with the goal of spinal decompression by drawing the vertebral bodies apart and their segments, associated segments. We can create distraction or decompression moments within the discal space, as well as along the facet joints. So that can address a number of different problems, either directly within the joint, like intra-articular within the joint from a discal level, within the facets of that joint at an interarticular level between the facet joints that combine spinal segments, or from a sort of secondary perspective in terms of addressing things of, let's just say, issues of spinal nerve compression. So herniated disc pushing on the nerve, spinal stenosis, narrowing the vertebral foramen canal through which the nerve is going to pass. So those are the primary indications. And really, you're trying to, again, in that vein, is reduction of radicular signs or signs that are associated with nerve pathology. So pain, tingling, numbness, muscular weakness, typically down the distribution of whatever nerve is experiencing that dysfunction or that compression. The other things we can use traction for are going to be reduction of muscle guarding or spasm with a prolonged stretch approach, reduction of joint pain via neurophysiological pathways. So there's that gating mechanism associated with the feedback, the mechanical sensory feedback you're getting from the traction. And then also increasing range of motion by distracting joint surfaces such as the facet joints to allow for more mobility. So contraindications, or excuse me, not contraindications, not there yet. Conditions, disc protrusion is a major one. You're typically using traction on disc protrusion issues, disc herniation, things of that nature, right? So spinal stenosis, again, the narrowing of the vertebral foramen through which the spinal nerves will pass at the root level, or just degenerative joint disease of either the facet joints or some of the joints of the spine, typically of the spine for the most part, of the most often lumbar or cervical spine. There's some examples of manual traction. There's some examples of mechanical traction. This chart, again, we love charts, right? This should be sort of the holy grail of what you're trying to do here, okay? So in terms of knowing traction, I want you to just understand that in order to get, basically, to get joint distraction, you usually need, it varies, but 25 to 30 pounds of force. So what you'll see here, depending on what the goal is, variations of and manipulations of the poundage of force delivered by the traction for different things. In conjunction with different combinations of hold relax times, depending on the treatment outcome, as well as total treatment duration times. So goal of treatment, initial phase or the acute phase, you're starting low with the static traction, low duration of overall treatment time. When joint distraction is the goal, we have to implement a poundage that's anywhere between 20 and 30 pounds to get us to this level. We're going to manipulate hold times and off times and the treatment duration. And then the rest here, decreasing of muscle spasm or discal pathology with a soft tissue stretch. You can see how the parameters change. So know this chart and you'll be in good shape. The difference between static and intermittent traction is pretty self-explanatory, right? Static traction is just going to provide a prolonged hold, and you're going to use this for specific things, as you just saw in that previous chart. So know the difference. You're also going to have different combinations of intermittent tractions, which means that there's a hold coupled with a rest break. So we're going to use intermittent traction for things like facet distraction, disc protrusion, where there's different ratios associated with hold times versus traction times. So please just review the chart to know why you would use each one of those. There's your lumbar traction, primarily done in supine, not often done in prone. Don't really need to know that. Know the differences as well between lumbar and cervical traction treatment. Here are some treatment times. Here's the overall frequency you can use the treatment. Please understand the contraindications associated. They're going to be pretty much the same for cervical and lumbar traction, with maybe a few minor changes, but here are our precautions. Here are our contraindications. Be able to apply those to case scenarios. These are some potential questions you can ask. There's some good ones in Physio U as well that will give you insight into the patient's history, that whether tells you whether or not they are contraindicated, precluded from being able to engage in the traction, and then how you go about documenting. So patient position, the type of traction you did, the amount of force, and how much time you had relaxation time versus